Good morning, everyone. Today we have Dr. Carissa Chetty, and she's going to talk about CAR T cell therapy. Dr. Carissa is a specialist haematopathologist. She qualified in 2022 and works at Ampath Laboratory National Reference Lab since February 2023. The special interests of flow cytometry, quality management, and clinical trials. In her spare time, she loves to read, bake, and sew. Thank you so much, Carissa, for presenting to us. We're looking forward to this interesting topic. As we know, there's quite a lot of research being done in CAR T cell therapy, and a lot of us actually knows a lot about this. So this is going to be a nice, interesting presentation. Thank you.
Good morning, everyone. Thank you for the kind introduction, Michelle, and thank you for the invitation to present at this platform. Today's presentation is on CAR T cell therapy, and as you said, this sort of therapy, immunotherapy, has really come to the forefront in the last decade or so, and we will definitely be hearing more about it in the future. So I thought it's nice just to refresh our knowledge a little bit. So I'm going to try to give you CAR T cells in a nutshell. As you know, the topic is really, it's a very big one and quite complex, and I don't think that it's possible to do justice with a comprehensive talk in such a short period of time. I understand this is meant to be something like a 30-minute slot, so I'm going to try to give you an overview just with what I felt was the most important points about CAR T cells. So for today's presentation, we're just going to go through what are CAR T cells, the current uses and the clinical trials that are ongoing for CAR T cells, the side effects, and then some of the more specialized or novel strategies that are being researched for therapy for treatment of malignancies and autoimmune disease. So what is a CAR T cell? It is a chimeric antigen receptor T cell, and this is a type of immunotherapy that uses genetically modified T cells to target cancer cells. It's manufactured mainly from autologous T lymphocytes. Sometimes it can be allogeneic, to express a synthetic receptor that recognizes specific tumor antigens. And overall has really improved progression-free and overall survival in a number of relapsed and refractory B-cell malignancies. And now it is being explored for the treatment of other malignancies and autoimmune disease. So if you're wondering where the word chimeric or chimera comes from, it is actually related to the word chimera, which is in Greek mythology, this horrific-looking fire-breathing monster with a lion's head and a goat's body and a serpent's tail. And the reason being is that it refers to an organism that contains a mixture of genetically different tissues. So we are taking the human or the patient's T cell and genetically modifying it. So let's have a look at how, sorry, I think that there's a banner on top, but I'm not sure how to get rid of that. Let's look at how CAR T cells compare to conventional T cells. With conventional T cells, these have a native T cell receptor, and it's only able to recognize antigen with the assistance of antigen-presenting cells. So this is sort of the middleman, the antigen-presenting cell that must introduce the antigen to the conventional T cell receptor, and it does this by breaking down the antigen into smaller peptides and then presenting it on an MHC molecule, which is the only way the conventional T cell receptor can recognize an antigen. If you compare this to the CAR T cell, the CAR T cell does not make use of this conventional T cell receptor. Instead, it bypasses the middleman and is able to recognize surface antigens directly without the assistance of the antigen-presenting cell or MHC presentation. The downside of the CAR T cell is that, unlike conventional T cells, it's not able to recognize intracellular antigens, but rather only surface expressed antigens. Take a closer look at how the CAR T cell works. On the bottom left, we have the basic point. On the bottom left, we have the CAR T cell, which still usually retains its T cell receptor, its original T cell receptor. And then it is equipped with this variable fragment single chain, which is antibody derived, and that binds directly to the antigen on the tumor cell without the assistance of MHC. There's MHC isolated. And then similar to how conventional T cells work, granzyme and perforin are released, and that causes apoptosis of tumor cells. Here we're taking a more zoomed in look at the CAR T cell structure. So here's the CAR T cell expressing its chimeric antigen receptor. And the chimeric antigen receptor is made up of three components: the ectodomain, which, like I said, is a single chain variable fragment derived from an antibody. So the way in which the the receptor recognizes antigen is very similar to how an antibody recognizes antigen. Then you have the transmembrane domain, which is just responsible for anchoring the ectodomain to the cell membrane, and it also is involved somewhat in cytokine release. And then the endodomain, which consists of the CD3 zeta molecule, which is the signaling element of the cell, involved in activation, survival, and persistence of the CAR T cell, as well as a co-stimulatory domain in CAR T cell generation. I'll go on to that now. So let's have a look at the sort of simplified overview of the manufacturing process. Here we have the patient, and then peripheral blood mononuclear cells are extracted from the patient's peripheral blood. T cells are isolated and concentrated, and these are usually alpha beta T cells. And then a recombinant virus is usually used to insert the DNA construct encoding the part into the T cell. Non-viral vectors can also be used instead of the antiviruses. The CAR T cells are multiplied before or amplified before they are put back into the patient's bloodstream. And generally, prior to infusing the CAR T cells, lymphodepleting chemotherapy is usually given, and this helps to prime the immune system and remove other immune cells that might counteract the effect of the CAR T cell. And then what's quite interesting is that after the CAR T cells are administered, there is the possibility, or well, actually it is desired, that the CAR T cell population expands post-infusion and can remain in the patient's immune system. So I'm going to backtrack a little bit and have a quick look at the history. We have come a long way in the last, 60 years, 70 years or so. It was only in 1960 that the thymus was identified as the site of T cell development by an immunologist, Jacques Miller. And then some years later, about 25 years later, the first sort of attempt to use T cells as a form of immunotherapy was made. And that was by Dr. Steven Rosenberg, who tried to use tumor-infiltrating lymphocytes to treat solid tumors. And then in the late 1980s, two separate doctors, a Dr. Kurosawa and a Dr. Escher, with their separate teams in separate countries, interestingly, both worked on something that was like a CAR T cell. So they used T cells and they modified the T cell receptor. And then by 1993, we had first generation CAR T cells. And in 2002, we have second generation CAR T cells. And in the early 20 noughties, what is it called? These research was done looking at the effect of CAR T cells, and then we have the reports of CD19 CAR T cell therapy in patients in the early 2010s. And then by 2017, the first CD19 CAR T cell was FDA approved. I won't bore you too much with the details about this, but over the years, we now have 5 different generations of CAR T cells in existence. So the first form had only the T cell receptor with the CD3 zeta molecule, but it was found to be insufficiently activated and had insufficient persistence in the immune system. So the second generation CAR T cell incorporated the addition of a co-stimulatory molecule to stimulate the T cell further and allow it to persist in the immune system. The third generation added to that by adding 2 co-stimulatory domains instead of 1. And then the fourth generation CAR T cell, which is actually called truck, so you can excuse my vehicle-related jokes, it's not just me. But these are unrestricted cytokine-initiated killing T cells, and these have a cytokine inducer to enhance the release of cytokines to promote anti-tumor activity. And then lastly, the 5th generation CAR T cell has all of the previous generations effects, plus a JAK-STAT3/5 signaling domain to further activate the T cell. And here you might also have Treg inactivation, where the original T cell receptor on the T cell is removed. And this allows better incorporation of the CAR receptor. It also prevents the original T cell receptor from binding to antigens that you don't want it. So to quickly look at the current uses and clinical trials, currently there are 6 approved CAR T cell constructs. All of these are 2nd generation, and they all target hematological malignancies. There are 4 CD19 targeting CAR T cells. This is Kymriah, and that was the first CAR T cell to be approved by the FDA and EMA for the treatment of children and young adults with relapsed and refractory B-ALL, the acute lymphoblastic lymphoma, leukemia, and B-cell lymphomas. And then thereafter followed Yescarta, Tecartus, and Breyanzi. And these are now approved for the treatment of relapsed and refractory high-grade B-cell lymphomas, particularly the large B-cell lymphomas like DLBCL, high-grade B-cell lymphoma, and transformed follicular lymphoma. And this has shown to have an MRD negative overall remission of 81% for B-ALL and a 6-month overall survival rate of 90%. And it has been shown to be superior to standard chemotherapy for relapsed and refractory disease. And what was quite interesting is that these studies showed that the CAR T cells were persistent in the bloodstream or immune system for at least a year after infusion. So the sort of therapy loss in the immune system. The second type of CAR T cell that was approved is the BCMA targeting or B cell maturation antigen, which is present on plasma cells. And this was approved for the treatment of relapsed and refractory myeloma in 2021 and 2022. These have prolonged treatment-free remissions compared with standard chemo and radiotherapy, but it's not necessarily curative like CD19 targeting CAR T cell therapy is for the B-cell lymphomas. I just want to touch a bit on what we are looking at in other malignancies. AML, as you know, has quite a high mortality and morbidity rate in the elderly population, but unfortunately to date there are no FDA or EMA approved CAR T cells for the therapy of AML. And the main challenges with this is that there is an absence of an ideal target antigen, because most of the antigens present on myeloid leukemic cells are also present on healthy hematopoietic stem cells. So to target that antigen would mean to attack healthy cells as well, or result in on-target off-tumor toxicity. The AML tumor is also very heterogeneous. There are multiple subclones that are always changing, especially at relapse. And then the immune system or the bone marrow microenvironment is designed to evade attack by immune cells. The tumor produces immunosuppressive metabolites that impede immunotherapy, and the tumor microenvironment itself is acidotic, which suppresses T cell activation. Some of the antigens that they are trying to target in the context of AML are CD123 and CD33. Those are the most common ones. The problem with CD123 is that it's also expressed on endothelial cells. So attacking CD123 results in potential capillary leak syndrome because CD123 is present on endothelial cells. CD33 is present on, is thought to be present on Kupffer cells and liver cells. So to target CD33 often results in direct toxicity. And then the other one that they are looking at is CD7, just quite an interesting one. It's aberrantly expressed in AML. And the difficulty here is that CD7 is also expressed on T cells. So you might end up with a situation where CAR T cells attack each other or other T cells. The only way to get about that is to knock out the CD7 expressing gene so that the T cells no longer have CD7. It's very interesting. In solid tumors, we have much of the same challenges as experienced in AML. And in addition to antigen heterogeneity and antigen escape for changing in the antigens, you also have limited CAR T cell infiltration into the solid tumor, not only because of the immunosuppressive tumor microenvironment, but also because the solid tumors have a physical barrier to penetration by CAR T cells. So there's fibrous tissue and stroma and extracellular matrix that makes it difficult for the CAR T cell to be incorporated into the tumor. Some of the challenges that were experienced in the studies that were done is on target off-tumor effects. For instance, trastuzumab-based anti-HER2 CAR T-cell therapy was researched in a certain clinical trial, and this exhibited fatal cardiopulmonary toxicity in a patient who had metastatic colon cancer. And that was as a result of on-target off-tumor effects. So to date, there were no FDA and EMA approved CAR T cells, but just last month, very recently in China, a CLDN 18.2 CAR T cell, I'm not going to try to pronounce that name, was approved for the treatment of advanced gastric and gastroesophageal junction HER2 negative adenocarcinoma. So it really is becoming more popular, and I think we are more likely to see other countries approving CAR T cell therapy for certain malignancies, and hopefully South Africa in the future. A few words on autoimmune disease. This sort of therapy is being increasingly explored for the treatment of autoimmune disease because it can target autoreactive B cells and deplete the autoantibody load directly. The potential advantages are that it is highly specific in targeting the pathogenic autoimmune cells, and it also has a potential for long-term remission or cure, and will reduce the need for chronic immunosuppressive therapy. Most of the research done for autoimmune disease looks at SLE and rheumatoid arthritis, and specifically in SLE, CD19 targeted, so B-cell targeted CAR T-cell therapy achieved sustained remission and improved organ function. And what was nice is that it actually had lower systemic toxicity compared to treatment of B-cell malignancies, because the B-cell burden is lower in autoimmune disease compared to a B-cell lymphoma. Few words on side effects. Most common and most severe side effect, short-term side effect is cytokine release syndrome, with an incidence of 55.3%. And CRS is thought to be due to a cytokine storm-induced systemic inflammatory response. And this is characterized by the release of large amounts of inflammatory cytokines due to lymphocyte activation and widespread damage to tumor cells releasing their cellular content. The effects of this are hypotension, cardiac dysfunction, and multi-organ failure with endothelial damage and possible risk of microthrombi. One of the treatments that has been shown to be quite effective for CRS is an IL-6 monoclonal antibody as well as steroid therapy. The second most common and severe short-term side effect is ICANS, or immune effector cell-associated neurotoxicity syndrome, with an incidence of 37.2%. I'll just add here that while these are fairly common, mortality due to CRS and ICANS is actually thought to be fairly low. I think it's something like less than 1%. And ICANS presents with possibly with mild symptoms such as tremors, writing disorders, and speech difficulties, all the way up to more severe effects such as altered level of consciousness, ataxia, seizures, and cerebral edema. What's quite interesting is that daily handwriting tests in the months following CAR T-cell infusion can help to predict the onset of ICANS. The mechanism of this is thought to be somewhat similar to cytokine release syndrome, with activation of endothelial cells and immune cells. But here there's also breakdown of the blood-brain barrier and infiltration of the CAR T cells into the CNS itself. It's thought to share a mechanism with CRS, mainly because at least grade 1 CRS occurs prior to ICANS, and it is often preceded by fever. And similar to CRS, it does respond to treatment with steroids. Another treatment that may be used for ICANS, or that may be prophylactic, is an IL-1 antagonist. Few more words on short-term side effects, specifically hematological, because that's our interest. Immune effector cell-associated hematotoxicity, or ICAT, can occur, and this results in severe cytopenias, particularly neutropenia. And ICAT itself is graded according to the severity and duration of neutropenia. It might be early, less than 30 days, prolonged between 30 and 90 days, or late after 90 days of infusion. And here again, it's thought to be related to bone marrow suppression post-CAR T-cell infusion, related to the release of cytokines again, that was interleukin-6, but also lymphodepleting chemotherapy given prior to that may happen. Some of the other hematological effects that we see are prolonged PTT and hypofibrinogenemia, as well as DIC, and this is also related to cytokine release and endothelial damage. Others include immunocompromise resulting in infection, secondary HLH, graft versus host disease in the instance of allogeneic T cells. Then we have a whole host of other short-term side effects such as tumor lysis syndrome, cardiovascular, respiratory, GIT, renal, dermatological toxicity, as well as infection. So in terms of long-term side effects, because there are a number of long-term survivors, as a result of this therapy, there's also an increased risk of experiencing potentially life-threatening long-term complications. And these are defined as occurring more than 90 days post-CAR T-cell therapy. Cytopenias rarely occur after a year. Usually it is due to persistent ICAT, but one should also consider the possibility of relapse disease, a secondary malignancy, or ongoing infection. Infection itself is fairly common, and it is one of the biggest causes of late morbidity and mortality in these patients. And it is, of course, due to impaired cellular and humoral immunity, resulting in persistent B-cell aplasia, hypogammaglobulinemia, and protracted CD4 T-cell deficiency. Some of the more common infections to occur are PCP and reactivation of herpes virus, just to name a few. Then you may also have delayed neurotoxicities. This is something that is similar to a Parkinsonian type disorder with movement and neurocognitive impairment. And then one big question is, what is the risk of secondary malignancy, and does CAR T-cell result in secondary malignancy, as can chemo and radiotherapy? So to date, there's no strong evidence to show that the second primary malignancy frequency is higher with CAR T-cell therapy compared to standard of care strategies, so compared to chemo and radiotherapy. There is also this question of whether CAR T-cell therapy can cause T-cell lymphomas due to insertional oncogenesis, because we are genetically interfering with T cells. And here, I think the final answer is that they don't exactly know. Of the more than 27,000 doses of CAR T cells that were administered, and these are the 6 approved CAR T cells, the overall incidence of T cell cancers was approximately 0.1%, which does not seem drastically increased. But the CAR transgene was actually detected in the malignant clone in some of those cases. They actually went on to say that the true incidence of secondary T-cell malignancy might be underestimated, because when a patient presents with signs and symptoms of a malignancy, it might be assumed that it is the original malignancy, usually a B-cell malignancy, and might not be further investigated adequately. So they could actually potentially be T-cell malignancies. But the FDA has gone on to say, and I think we can all agree, that the benefit of CAR T-cell therapy outweighs the risk, but lifelong monitoring of these patients is advised. And most of these patients are enrolled in lifelong monitoring trials. And lastly, just a few words on this more specialized CAR T cells and novel strategies that are being researched at the moment. These are sort of the very fancy CARs, the sort of Teslas of the CARs, almost non-existent. So because of the side effects of CAR T cells and because they have been infused into the patient, they're looking at ways in which you can switch off the CAR. And they've come up with some very clever ways. So the one is to incorporate a sort of safety switch in the form of another antigen, such as CD20. So if you can get the CAR T cell to express CD20, then you can switch off the CAR by administering rituximab. Another method is to have the T cell express two separate CARs, and full activation will only occur when both of those CARs are bound to respective antigens. So this makes the CAR T cell more specific for the tumor. It will not bind to something that only has one of those antigens. You can also incorporate an ICAR, which is an inhibitory receptor. This switches off when it encounters an unintended healthy antigen. And then you have a supraCAR, which this uses a leucine zipper adapter, which is separately administered. And it basically, when the T cell encounters a healthy antigen, it will cause it to inactivate. And when it encounters a tumor antigen, it will cause it to activate. And then there are a few strategies that they are looking at to improve efficacy and adaptability. So one method to reduce immune evasion, because cancer cells often, their tumor antigens change in expression or they stop expressing tumor antigens. So one method is to use a tandem or a dual CAR. These types of CAR T cells either have two antigen binding domains or two separate CARs on the T cell, recognizing separate antigens. So when one of those receptors are bound, the CAR T cell is activated. Or you can give a sort of CAR T cell cocktail with multiple types of CARs, targeting multiple different antigens at the same time. For example, you could target CD123 and CD33 at the same time. Another method is to sort of recruit bystander T cells, so the unadapted T cells. And you can do this by using a CAR that is incorporated with a BiTE. The BiTE is a bispecific T cell engager. Sorry for all of the technological speak, but the bispecific T cell engager, it binds to CD3 on one side and it binds the tumor antigen on the other side. So it helps to recruit the bystander T cells to the tumor microenvironment. And then you can also make the CAR T cell more adaptable. These are universal adapter, modular, or switchable CAR T cells. Here, the CAR T cell recognizes a common adapter that is administered separately. The adapter molecules are specific to the tumor antigen, and the adapter acts as a sort of bridge where it binds the tumor antigen on one side and the CAR on the other side. So you can give the CAR T cell, and then you give the adapter separately, and you can change or switch out the adapter as needed to target different antigens. And the advantages here is that you have more flexible targeting and multi-targeting, and it also incorporates a sort of safety mechanism because you can withdraw the adapter should you want to discontinue CAR T cell therapy. And then lastly, we have CAR NK cells and CAR macrophages. Here we are trying to harness the special or unique effects of natural killer cells and macrophages that they have as anti-tumor cells. CAR NK cells have gained a lot of popularity, and I think that these are also FDA approved. So here they want to combine the innate cytotoxicity of NK cells by adding a CAR receptor to it. Here you have the potential of using allogeneic natural killer cells instead of patient NK cells. And the main advantage of this is that the NK cell does not have a T cell receptor like a T cell does, so there's little to no risk of graft versus host disease. There's also a lower risk of CRS and neurotoxicity. Because we're using allogeneic products, there is potential to produce off-the-shelf CAR NK cells and to allow for large-scale manufacturing or easy manufacturing. Macrophages, these have the special ability to infiltrate solid tumors and to phagocytose tumor cells and to present antigen to other cells in the immune system. Here, CAR macrophages that were researched are mainly autologous, so mainly patients' own cells, but there is a potential to use allogeneic CAR macrophages because as with NK cells, they do not have a T cell receptor, so there is no risk of graft versus host disease. The disadvantage with the CAR macrophage is that it has relatively short persistence in the immune system, and there has been shown to be quite a high risk of host rejection. And then lastly, a few words on CAR T cell therapy in South Africa. In South Africa, unfortunately, CAR T cells are to date only available in the context of clinical trials. There has recently been a phase 1 safety trial at Pretoria East Hospital. This trial is actually recently closed. They've recruited all of their subjects, completed the trial. And it is actually the only center in Africa that produces and infuses CAR T cells themselves. We are currently still awaiting Section 21 approval by SAPRA, and I think that could only possibly occur after we have the results of clinical trials done in South Africa. And one of the main challenges that are experienced is that CAR T cells are not just drugs, they are simultaneously drugs, genetically modified organisms, and human cell-based. So there's a lot of red tape that we need to go through in order to have approval of this treatment. Currently, South Africa lacks specific regulatory framework for advanced cellular and gene therapy. But I think we can watch the space, and hopefully in the years to come, we will be able to have CAR T cell therapy approved in South Africa. So in conclusion, CAR T cells are a successful cell-based immunotherapy for relapsed and refractory B-ALL and B-cell lymphomas. And it is also potential therapy for other malignancies and autoimmune disease that is being researched. Unfortunately, the main challenges are cost, production complexity, and regulatory challenges. And that is it for me. I found that the first article by Hendricks et al. Is really a very interesting one, explaining the difficulties we had in gaining approval of cellular immune therapy in South Africa. I did not go over time too much.
Thank you so much, Carissa. Yeah, this is an interesting presentation, because I think sometimes people that's already on chemotherapy, they'll go and read up a lot, and they're also desperate for other treatment options. So they will phone you and ask about CAR T therapy because that's the new novel therapy. And unfortunately, it's not that available in South Africa. But I think it's important for all doctors to actually know about it, because patients do ask.
Yeah. And they are, like I said, at Dave Britton's practice, ongoing trials looking at CAR CD19 targeted CAR T cells as well as CAR NK cells. We don't yet have the results of that, but overseas it has been shown to be promising.
In South Africa, one of the few countries that it hasn't been approved for regular use. So it's either approved, and what about other countries in the world? Other countries in the world, has it been approved?
In China, it has been approved, and I believe it is also being used in India and some places. Not sure about other countries, so it has FDA approval, EMA approval. China has one for solid tumors now.
So obviously, it's probably an expensive kind of therapy. So, but you only get the infusion then once. So they take your own T cells, they make the CAR T cells, and they reinfuse it. Is it only a once, or do you need to have?
The idea is to do it once, and then the CAR T cell population can expand and remain in the immune system. But that said, I think that they can give you a sort of pop-up, if you will, similar to how you can give somebody a stem cell transplant and then repeat it. But what's quite interesting is that although those CAR T cell therapies that are approved, they have pharmaceutical names, they are still not off-the-shelf products. They are still using patient T cells, even though it has a pharmaceutical name, which I found interesting. So you think that if something has a drug name, it's not something they took from a patient and modified and gave it back to you, but it is.
Probably the way that they manufactured it, giving the name to it.
I think it's the way in which it's manufactured. I think they all have different, slightly different processes.
Strange names.
Yeah. And the virus or the lentivirus or the vector they use to insert the DNA construct. Yeah. But we really have come a very long way. I think some years ago it probably seemed like pie in the sky. Now it is becoming a reality.
But as I said, I've experienced a friend of ours. She had a diffuse large B cell, and all therapies failed, and it's a last resort. They used CAR T cells and initially see I think the renal response was all of a sudden, and she died after the first one. So it was really promising at that stage because that was the only one, but unfortunately it didn't work.
Was it given in South Africa?
Yeah, that Britain.
Oh, David responses. I'm not sure if there are any line, if there's anyone that can would like to ask anything.
Any questions on the people joining?
I'll stop sharing so that I can see if there are any. Yeah. I don't see any questions on there.